Hello everyone, welcome to another class of Pediatrics Simplified. Today we will be beginning pediatric cardiology with a very short topic, that is fetal circulation. Fetal circulation is a short topic, but questions do come. Questions come frequently because it is a topic of understanding rather than mugging up. Okay, so basics of fetal circulation, we will understand the concepts, we will do some questions, and we will understand them some clinical implications. Okay, so let's start. So there are majorly four differences between the pediatric and adult circulation, right? So understanding these differences will lead to easier understanding of pediatric cardiology. So first is the site of oxygenation. In the adults, the site of oxygenation is the lung. Okay, so and it has higher oxygen efficiency. But in fetal circulation, the site of oxygenation is placenta. Everything comes from the placenta. The nutrient, the oxygen, and everything comes from the placenta. It has low vascular resistance. Okay, the PO2 in the umbilical vein is only 30 to 35 mm of Hg. It is a question. Okay. Second, pulmonary and systemic pressure. In the fetus, there is high pulmonary vascular resistance. Okay, because the lung is compressed, the lung vessels are vasoconstricted. Okay, so there is high pulmonary vascular resistance. Similarly, there is low systemic resistance, but it is the case is opposite in case of adults. In adults, we have low pulmonary pressure. Whenever the baby is born, when the baby has his first cry, the pulmonary vasculature opens up. The pulmonary vascular resistance, the vessels that are vasoconstricted gradually open, become vasodilated, and the pulmonary vascular resistance falls. Okay, this pulmonary vascular resistance, the fall continues for 6 to 8 weeks. Then the it gradually changes into the adult circuit. You're understanding? Okay. So in adults, there is low pulmonary pressure because the lung is opened up, and high systemic pressure. Now, series versus parallel. In the adult circulation, it is a series circuit. I mean, the blood comes to the right ventricle, from the right ventricle to the lungs, from there to the left ventricle, and from there to the body. But in fetal circulation, it is a parallel circuit. Both ventricles work simultaneously. Okay, right ventricle pumps whatever blood it receives, left ventricle pumps whatever blood it receives. Okay, it is called a parallel circulation. Both of them are working simultaneously. And the fourth difference, presence of the shunts. There is no shunt in the adult circulation. If there is a shunt, there is a disease. Okay, but in fetal circulation, for effective functioning of the fetal circulation, there are shunts. There are physiological shunts that are closed after the baby is born. The shunts are Ductus Venosus, Foramen Ovale, and Ductus Arteriosus. Okay, placenta we can consider it as a shunt, but major shunts are Ductus Venosus, Foramen Ovale, and Ductus Arteriosus. But in adults, there are no such shunts. Then we come to the umbilical cord and placenta. As we know, there are two umbilical arteries and one umbilical vein. Okay, this slide is very meticulously prepared from taking the information from various pediatric books, including Nelson, Park. Okay, and then it is converted to PowerPoint for your effective understanding. And the I have made it different colors for your easier imprinting into your mind. Okay, so there are two umbilical arteries and one umbilical vein. Okay, always whenever you resuscitate a baby, whenever you cut the umbilical cord, we see whether there are these three structures or not. Two umbilical arteries and one umbilical vein. See, this is the umbilical vein. Okay, this is the expansile structure. The umbilical artery is thick walled. Okay, non-expansile. So the placenta facts. Site of oxygenation in fetus, as we know, the lung of the fetus. Lowest vascular resistance in the fetal circulation is placenta. Everything is a question. Okay, these are I mean, you read this topic, the slides will be uploaded in the Telegram channel. You read it continuously, read it. I mean, one day if you read, you will it feels like you will understand, but after some days you will forget. So revise it continuously. Okay, it is in a PowerPoint form. so you can revise anywhere, you can revise in your phone also. Okay, so it receives the largest combined, the placenta receives the largest combined right ventricle plus left ventricle output. The oxygen exchange efficiency is less than the postnatal lungs, obviously understandable, because just the placenta functions just for the fetus. Okay, it has no it has, along with the exchange of gases, it also does the exchange of nutrients. Okay, so somewhere the alone the efficacy and functioning will be less. Okay, so the umbilical vein blood divides at liver. 50% goes into the hepatic circulation, 50% will go into the ductus venosus and drain into the IVC. We will read it in detail just in the next slide. So there are two umbilical arteries. Umbilical arteries carry deoxygenated blood, okay, from the fetus. They have muscular wall, as we can see. This is the muscular wall part. Okay, branches. The both the umbilical arteries are the branches of the internal iliac artery. This is a question. This is a neat question. Okay. Then one umbilical vein, the umbilical vein, remember the umbilical vein carries the oxygenated blood. Okay, they will trick you here. Oxygenated blood from the placenta to the fetus, and okay, it is thin wall. You can see the thin wall. Saturation is highest at the umbilical vein. There is a sequence of saturation. As we go on reading, you can understand. Now you understood there is a placenta. From the placenta, the umbilical vein goes to the fetus. From the fetus, the two umbilical arteries drain into the placenta. The umbilical arteries carry the deoxygenated blood. The umbilical vein carries the oxygenated blood. Obviously, in the umbilical vein, the oxygen saturation will be highest. Okay, Watton's jelly. Everything is put together into a jelly format. In the Watton's jelly, it is actually a jelly-like thing in which these structures are embedded. It is a gelatinous substance holding the cord structures together, preventing the compression. Okay, anywhere there is fetal distress, the cord structure should not be compromised, because these are the only structures that provide the nutrition and exchange of gases. So, in order to prevent the compression of the cord, the Watton's jelly does its part. Okay. Now, course of the fetal circulation. You have a basic idea about fetal circulation: placenta, fetus, umbilical vein, umbilical artery. Okay. Now, from the placenta to the umbilical vein, the oxygenated blood saturation, we read oxygenated blood saturation is about 80%, leaves the placenta via the umbilical vein. Okay. From the placenta, the blood goes to the umbilical vein. Here is from the placenta, here is the umbilical vein, the red part. Okay. So mark this carefully. This is the umbilical vein. Now, the umbilical vein, when the umbilical vein reaches at the level of the liver, it splits into two. 50% drains into the hepatic circulation, 50% drains into the inferior vena cava. Okay, so the umbilical vein splits at the liver. 50% goes into the hepatic circulation and 50% via the ductus venosus. This is one of the important shunts in the fetal circulation. Okay, it reaches the inferior vena cava. Okay, once you understand it, there are very less things to mug up. Okay, now the inferior vena cava, the blood came from the placenta to the inferior vena cava. Okay, now this part is the inferior vena cava. Okay, now the inferior vena cava will carry the blood from the lower part of the body. Okay, now the saturation of the blood in the inferior vena cava, since the inferior vena cava has also brought the blood from the lower parts of the body, and the blood from via the ductus venosus, the blood is mixed, so the saturation will slightly fall. Okay, so the mixed blood enters the right atrium. Understood now what is mixed blood? The deoxygenated blood carried by the inferior vena cava from the lower parts of the body. One, the blood carried by the ductus venosus, I mean the umbilical vein via the ductus venosus from the placenta. Those two bloods are mixed. Okay, where they drain into the right atrium. At the right atrium, two-third goes into the right ventricle. From the right atrium to the right ventricle, two-third, whatever amount of blood came from the right atrium to the right atrium, one-third of it goes to the left atrium via the foramen ovale. Okay, The foramen ovale also has two parts, the crista dividens and the eustachian valve. Okay, you only remember the parts now. We will go into detail. So just remember, just imagine in your mind the flow of blood. uh, Whatever blood came to the right atrium, one third of it goes to the left atrium, two third of it comes to the right ventricle. Okay, now if an adult circulation, if it would have been an adult circulation, what had been the format? The right ventricle, now the blood is in the right ventricle. From the right atrium, two third of the blood is in the right ventricle. The right ventricle will pump into the lung. But in fetal circulation, there is no lung. All the vessels are vasoconstricted. That's why we say the lung of the fetal circulation is the placenta, and the right ventricle has nowhere to pump. Okay, now the right ventricle receives the right ventricle. And one more thing, now what happens to the saturation of the blood, the in the right ventricle, whether it is the same saturation as in the inferior vena cava? No, because the right ventricle, whatever blood is received by the right atrium, we read one third goes into the left atrium, two third comes into the right ventricle, to the right ventricle, right? So now what amount of blood is received in the right atrium? Right, the right atrium not only receives the blood from the inferior vena cava, it also receives the blood from the superior vena cava. So superior vena cava also brings the deoxygenated blood from the upper parts of the body. So now the saturation of the blood in the right atrium is further decreased. Okay, so the blood from the inferior vena cava, superior vena cava, in the right atrium, one third of it goes to the left atrium, two third of it comes to the right ventricle. And so whatever blood goes to the left atrium comes to the left ventricle, and the left ventricle pumps into the ascending aorta that supplies the head, neck, coronary. Okay, because we have to give importance to the important structures. Okay, what are the important structures? The head and neck structures. So they first they receive blood. Okay, then we consider the other things. That's nature's priority. Now the right ventricle, what does it do? It should drain to the pulmonary trunk, but 85% of the blood bypass via the ductus arteriosus, because there is high pulmonary vascular resistance. We are talking of fetus in utero. The lungs have not opened. There is pulmonary vasoconstriction. There is high pulmonary vascular resistance. So the blood could not enter. Still 15% enter. Rest 85% go into the descending aorta via the ductus arteriosus. Okay, only 5 to 15% reaches the lungs. Now the descending aorta supplies the rest of the body, the lower part of the body. 65% blood returns to the placenta via the two umbilical arteries for reoxygenation. Now understood the circulation. 35% perfuses the fetal tissues. Okay, all these numbers when you read repeatedly you can remember. Understood? So from the placenta via the umbilical vein, via the ductus venosus, via the inferior vena cava, into the right atrium, into the right ventricle, from the right ventricle via the ductus arteriosus into the descending aorta, from the left ventricle, from the left atrium to the left ventricle, from the left ventricle via ascending aorta to the upper part of the body, from the lower part of the body. After 35% of the blood goes into the fetal tissues, oxygenates them, 65% of the blood returns back to the placenta for reoxygenation. Remember this, what to forget. Okay, now the baby is born, the shunts should close, because fetal circulation and postnatal circulation are completely different things. So all three shunts close after birth as the circulation transitions from fetal to adult pattern. So first, ductus venosus. Ductus venosus, you understood? This part is the ductus venosus. This is the umbilical vein. This is the portal vein. This is the inferior vena cava. Umbilical vein blood goes 50% goes into the into the hepatic circulation, and rest 50% into the inferior vena cava. Understood this part? Now what does the ductus venosus? These are the points. These are the salient points of regarding each structure. So the ductus venosus connects the umbilical vein with the inferior vena cava. Understood? 50% of the umbilical vein blood bypasses the liver via the this part. Just I am zooming in. 50% of the blood bypasses the blood bypasses the liver via the ductus venosus. The umbilical vein, just a second. The umbilical vein blood flow stops at birth. Okay, there is no need at birth. The pulmonary vasculature is open now. The baby has cried. The lung vasculature, there is vasodilation. There is decreased pulmonary vascular resistance. The placenta is cut off. So there is no blood flow in the umbilical vein. Right. So the umbilical vein blood flow stops. So the functional closure of ductus venosus is within few hours of birth. Okay, and the true closure, or the we call it anatomic closure, is on day 7 of life. What it becomes, it is in the adult, it becomes ligamentum venosum. Okay, ductus venosus in adults, the remnant of the ductus venosus in adult is called a ligamentum venosum. Now come to foramen ovale. This is the foramen ovale through which one third of the blood goes from the left atrium to the the right atrium to the left atrium. Okay, when you see a diagram, see, this diagram is of a relatively older child. How we know? Because the left ventricle is thickened. In adult circulation, the left ventricle is thickened, but in fetal circulation, the right ventricle is thickened, because right ventricle pumps the blood via the ductus arteriosus into the descending aorta. So there is a greater amount of blood that comes to the right ventricle. So the right ventricle pumps the greater amount of blood. The ventricle needs more force. Okay. So, but in adult, it is different. Gradually, as the shunts are closed, the amount of blood that the left ventricle receives is considerably higher than the right ventricle. So the walls are thickened. Okay, that takes time, around 6 to 8 weeks. So what about the foramen ovale? Foramen ovale, it is a connection between the right atrium and the left atrium. One third of the inferior vena cava blood crosses via the foramen ovale, kept open by, as I told, the structures, eustachian valve and crista dividens. At birth, sorry, at birth, the ductus venosus closes, and just a second, this pencil is not working. Okay, the remember about foramen ovale. The questions that are asked from ductus venosus, foramen ovale, and ductus arteriosus are: what are their adult remnants? Okay, what functions do they do in the fetal circulation? Right. Okay, so an important question regarding fossa ovalis. Your 2 to 3 times the questions have been asked regarding fossa ovalis. It is the remnant of foramen ovale. If the foramen ovale is persistently open, we call it fossa ovalis. Similarly, the true closure or the anatomic closure is at 3 months. Functional closure, we say, major books say within few hours. But questions usually do not ask, whenever the questions are asked, they do not ask the controversial question. They ask the questions regarding based on the facts and established facts. Okay. Now we come to ductus arteriosus. This is the ductus arteriosus. The pictures might vary because the pictures are this is a picture of the adult heart. Now there is a connection. So this picture is of a fetal heart. Not necessarily, because there can be patent ductus arteriosus. There is a disease. The shunt is not closed. So as the ductus arteriosus is patent, we call it PDA, patent ductus arteriosus. Okay, connects the pulmonary trunk with the descending aorta. You know all these. Location is it is present distal to the left subclavian artery. In utero, kept open due to low oxygen tension and high PGO2, PGE2. Most important prostaglandin to keep the ductus arteriosus open is PGE2. Okay, closure is stimulated by increased oxygen. Most important, decreased PGE2, increased acetylcholine, increased bradykinin. Anatomical closure occurs between day 10 to day 21 post birth, and physiological, as Nelson says, 10 to 15 hours. And what is the remnant called? Ligamentum arteriosum. Okay, understood this part. Ductus venosus, foramen ovale, and ductus arteriosus. Now, the pulmonary vascular resistance before and after birth. What happens to the pulmonary vascular resistance? As we know, in utero, the pulmonary vascular resistance is high due to relative hypoxia. There is why high? Due to relative hypoxia, there is pulmonary vasoconstriction. Understood? There is increased smooth muscle in the wall of the small pulmonary vessels. Understood? And the lungs are collapsed. In a collapsed lung, whatever vessels would be there, the resistance would be high. That's why 5 to 15% blood from the right ventricle goes into the uh, lung circulation. Rest 85% is drained via the ductus arteriosus into the descending aorta. Then after birth, what happens? There is an initial rapid fall. Why there is initial rapid fall? Due to mechanical lung expansion and sudden pulmonary vasodilatation. The second fall is between 6 to 8 weeks. That's why whenever any disease is present, we take 6 to 8 weeks to establish a disease. Sometimes there is a ventricular septal defect, but as the pulmonary vascular resistance is high, so we cannot the disease is not established at 6 to 8 weeks. When the pulmonary vascular remodeling occurs and the smooth muscle thickness decreases, all the diseases, if they are not established after birth, right after birth, that does not mean the child does not have a heart disease. It sometimes it takes 6 to 8 weeks to get manifested. Okay, then during the childhood there is slow sustained fall due to recruitment of more vessels and increase in number of alveolar units. So there is a initial rapid fall, acute fall at just after birth. At 6 to 8 weeks there is another fall, and during childhood there is another fall. Understood this? Okay. Now, what are the clinical implications pulmonary vascular resistance and congenital heart disease? Remember, pulmonary vascular resistance falls gradually after birth. If the pulmonary vascular resistance has not fallen sufficiently, a disease, if present, will not be manifested. Okay, sometimes we say at 2 to 3 days of life the heart is okay, there is no heart disease. No, we cannot say that. There may not be heart disease, but once the baby becomes 6 to 8 weeks, we need another examination. After that, when the pulmonary vascular resistance has completely fallen off, has completely come down to its normal value, after that, if there is no abnormality, we can say that the heart is normal. Okay, before 6 to 8 weeks, it's risky to say. So until the pulmonary vascular resistance falls sufficiently, left to right shunts are insignificant. Okay, now so the as the left to right shunts are insignificant, the congestive cardiac failure, there won't be congestion. The hole, even though the hole would be very small, and through that much blood will not come to cause congestive cardiac failure. Okay, understanding? Whatever you are not understanding, give a comment, I will explain. Okay, you can reach out, no problem. So in a large VST at birth, the pulmonary vascular resistance is still high. The left to right shunt is minimal. Okay, because as, as the resistance falls, the blood flow increases. As the blood flow increases, if there is a VST, the congestive cardiac failure occurs. Okay, the lung congestion occurs. If the pulmonary resistance is high, there is lesser blood flow, there is no congestion, so the CCF or congestive cardiac failure occurs at a later stage. At 6 to 8 weeks, when the pulmonary vascular resistance falls due to vascular remodeling, the left to right shunt increases and the CCF appears. Thus, CCF in large VST develops only after 6 to 8 weeks of age. Understood? PTA in preterm babies. The ductal smooth muscle is not, in preterm babies, the smooth muscle in the The ductal smooth muscles are not well developed, so the constrictor response to oxygen is not that good. And other than that, the pulmonary vascular resistance falls very rapidly in preterm. The left to right shunt starts early, so early CCF. So in preterm there is lesser musculature due to prematurity itself. So that's why the PDA, if we give greater amount of fluid also, there is a risk that the ductus arteriosus would open up. Okay, and they present with early CCF. What happens at high altitude? At high altitude there is hypoxia. Hypoxia causes pulmonary vasoconstriction. Pulmonary vasoconstriction increases the pulmonary vascular resistance. When the pulmonary vascular resistance increases, again the blood flow would be less, congestion would be less, CCF would appear later. Now let's see. Pulmonary arterioles are kept constricted. Left to right shunt stays minimal, no CCF. If the baby moves to sea level, the pulmonary vascular resistance falls, shunt increases, CCF appears. Understood? Okay. Now there is hyaline membrane disease. Hyaline membrane disease is a disease of the lung, fetal lung. Okay, the lung is not oxygenated properly. That means there is lesser oxygen. The lesser oxygen causes pulmonary vasoconstriction. So even if there is a VSD, there is increased pulmonary vascular resistance. So the CCF will appear late. Now let's see. There is hyaline membrane disease. There is hypoxia. There is sustained increase in pulmonary vascular resistance. Left to right shunt is reduced. Whenever there is a VSD, there will be left to right shunt. This is the left ventricle, this is the right ventricle, this is the VSD. The blood will come from the left ventricle to the right ventricle via the VSD, but here the resistance is very high. So due to hypoxia, vasoconstriction. So as the hyaline membrane disease improves, the PVR falls, oxygen rises, and sudden CCF may appear. Okay, so we should know the physiology to understand the disease mechanism. The child recovering from lung condition suddenly goes into CCF. Why? Because this is the reason. Okay, so this part is important. Saturation in the umbilical vein is the highest, 80%. Saturation in the inferior vena cava, from the umbilical vein via the ductus venosus into the inferior vena cava. Inferior vena cava carries the blood from the lower part of the body, so the saturation falls a bit, 70%. Partial pressure of oxygen, remember this, 30 to 35 mmHg. Sometimes they ask this, sometimes they ask this. Inferior vena cava 70% saturation. Left ventricle, when it comes to the left ventricle, left ventricle has 5% more oxygenated blood than the right ventricle, because right ventricle receives greater amount of blood from the upper and lower part of the body. Understood? Okay. So left ventricle has 65% saturation, right ventricle has 60% saturation, superior vena cava has 55% saturation, and the umbilical artery is less than 50% saturation, because they carry mostly deoxygenated blood into the placenta for reoxygenation. Similarly, PO2, mug it up. Mug it up, nothing to remember, mug it up. You understood what is the oxygenation sequence, but the numbers you have to mug up. So, partial pressure of oxygen is 30 to 35 mmHg in the umbilical vein and gradually decreases 26 to 28, then superior vena cava 12 to 14, and in the descending out at 24. Okay, then ventricular output in fetus, right ventricle pumps 55% of the total cardiac output, handles more, so walls are thicker than the left ventricle. As I said you, left ventricle pumps 45% of the total cardiac output. Cardiac output in the newborn is 350 ml per kg per minute. In the first 2 months it falls to 150 ml per kg per minute, and in the adult 75 to 80 ml per kg per minute. Okay, cardiac output is equal to heart rate into stroke volume. We know it, these are easy. So now comes the thing, heart rate into stroke volume. The fetal or the neonatal cardiac output is rate dependent, because the heart is less expansile, the heart cannot pump beyond its capacity. Okay, so the rate is higher in neonates, the rate is lesser in adults. Okay, so in adults, when there is bradycardia, there is compensatory increase in stroke volume and the cardiac output is maintained. Okay, bradycardia means heart rate decreased, and so stroke volume increased. Okay, but in fetus and early neonatal period, whenever there is fetal distress or hypoxia, there is bradycardia. Bradycardia means the heart rate decreased. Okay, now the stroke volume has to increase, but the fetus cannot increase the stroke volume. Okay, but stroke volume cannot be increased due to low compliance of the fetal heart, so the cardiac output falls. So whenever there is bradycardia, the cardiac output falls, the baby goes into shock like state. Okay, that's why we say the fetal heart is rate dependent. Okay, now let's do some questions. This much only. Okay, umbilical vein saturation, sorry, oxygen saturation in umbilical vein, how much? 80%. Now we read. Okay, which structure diverts the umbilical vein, the IVC blood into from the right atrium to the left atrium? Remember, foramen ovale, eustachian valve plus crystal evidence. Fate of the umbilical. Uh, sorry, the answer is revealed. What from the fate of the umbilical vein blood? What happens to them? 50% goes into the hepatic circulation, 50% goes into the inferior vena cava via the ductus venosus. Okay. Fate of the descending outer blood, 35. Oh, first you think. 65% goes into the placenta via the umbilical arteries, 35% into the fetal tissues for oxygenation. Why RV wall is thicker than LV? You understood 55-45 concept? 55% of the output and versus 45. So after birth, LV becomes dominant. What percent of blood passes through the lungs in placenta? Remember, 5 to 15%. Most important prostaglandin keeping the ductus arteriosus open in utero? Remember, PGE2. Most common stimulus causing ductus arteriosus closure after birth? Closure of ductus arteriosus. Rise in oxygen tension. Aspirin in pregnancy. What is the effect on ductus arteriosus? It constricts the ductus arteriosus in utero. Okay, so that might lead to PPHN, primary pulmonary hypertension of newborn. True anatomic closure of the foramen ovale occurs in 3 months after birth. I said that controversial part. What percent of combined ventricular output does the right ventricle handle? 55. Cardiac output in newborn versus adult. Remember, 350 ml per kg in newborn versus 75 to 80 ml per kg in adults. Okay. Clinical implications. Just go through it once. If you are watching YouTube, take a screenshot. If you are in Telegram, read from the slide. It's easy. If you are in any doubt, so tell me. Okay. Revision. Umbilical cord contains two umbilical arteries, one umbilical vein. In a Watton's jelly, umbilical vein saturation is 80%. Four shunts, placenta, ductus venosus, foramen ovale, ductus arteriosus, all complete. I think everybody is clear regarding the circulation. Ductus arteriosus closure, PGE2 keeps it open. Increased oxygen keeps closes it. All okay. Physiological within hours, anatomical within day 10 to 21. Pulmonary vascular resistance falls at birth, three stages of fall at birth, 6 to 8 weeks. Then childhood, we read it. Okay, at birth, 6 to 8 weeks, childhood, all complete. Fetal cardiac output is rate dependent. Bradycardia leads to shock like state. We read it. Distress bradycardia, cardiac output falls, shock like state. Okay, complete. Placenta, oxygenation site in the fetus, complete. Lowest vascular resistance, done. PO2 of the umbilical vein 30 to 35. We read it. Okay. Saturation order, you say, close your eyes and say. Umbilical vein, inferior vena cava, left ventricle, right ventricle, umbilical artery, less than 50%. Okay. Gone. This foramen ovale closure, I will say you whenever I will teach the anatomy of heart. I will tell you the foramen ovale closure. Now I intentionally did not say the foramen ovale closure. Wait for it. Okay. So VST plus CCF we read when the appearance of CCF and the what is that, uh, pulmonary vascular resistance. It is completely dependent upon that. We read four situations. CCF appears at 6 to 8 weeks when the pulmonary vascular resistance falls enough for a left to right shunt. PGE1 use opens or maintains the Ductus Arteriosus in cyanotic congenital heart disease. Side effect is we will leave it. We will go through it. Now focus on fetal circulation. Close your eyes, revise it once. From the placenta, how it comes to the fetus. From the fetus, how it comes to the placenta. How the entire circulation works. Okay. So that's it for fetal circulation. I will soon meet you in another class with another interesting topic. It takes time. It takes